for which we can submit papers and posters. So today we'll be having three speakers, Dr. Raj Kedar, Dr. Ashish Chawla, and Dr. Alok Jaju, followed by a quiz by Mitusha ma'am. So first off, we also have international speakers who are coming in for the international MRI teaching course, which is, as I said, on 29th October. And that is Dr. Scott Flam. So he's a cardiac imaging pioneer, and he'll be taking lectures on cardiac MRI, importance of cardiac MRI T2 star imaging and parallel imaging techniques and other efficiencies to enable high throughput in cardiac MRI. The second is Dr. Manohar Shroff, who's professor and chair of pediatric radiology at Sticks Kids Hospital in Toronto. These are the other few speakers who will be taking lectures such as pediatric cystic pelvic masses, pediatric solid pelvic masses, Dr. Heike Link, and Dr. Thomas Link, who will be taking on postoperative imaging hip and mimickers of inflammatory arthropathies. So this is the schedule for the MRI teaching course for day 1, 2, 3. And today we'll start off with the Prelude session now. So first is Dr. Raj Kedar. So he's a professor of radiology at University of South Florida and radiology chief in Tampa General Hospital. So he's a director of body imaging and fellowships in MSK faculty, vice president of Florida Imaging Radiological Society, vice president of Tower Imaging Centers Ventures. So he's also in the education course faculty at RSNA. He's got 100+ publications and 300+ presentations under his name, book chapters, editorial board members of multiple radiology journals. He got the best doctors in America. He was nominated for them in 2016, 17, 18, 19, and 20. And he also has a Teacher of the Year award in the Golden Apple Award 14. Program chairman of the Florida Radiological Society in 2018. And he's going to talk about characterization of renal masses. Next is Dr. Alok Jaju. So he's the program director and of Pediatric Neuroradiology Fellowship at St. Louis Children's Hospital in Chicago, and also the assistant professor at Northwestern University Feinweg School of Medicine. And his topic today is going to be pediatric fossa tumors. And last but not the least is Dr. Ashish Chawla. So he's done his MBBS and MD from KM Hospital. He's a senior consultant of Department of Radiology at Khoo Kuat Hospital in Singapore. And he's got fellowship in abdominal radiology at the University of Colorado, Denver. Fellowship in cardiothoracic radiology from the University of Colorado. He's authorized a textbook on thoracic imaging titled Thoracic Imaging Basics to Advanced. He's published around 80 articles in peer-reviewed journals and organized radiology courses for trainees. So his topic today is going to be imaging in cholangiocarcinoma. Again, this is just about the MRI teaching course, international edition, 3rd, 4th, and 5th November.
Good evening. It's my pleasure and honor to be part of this course, and I would like to thank Dr. Bhatnagar and Dr. Verma for inviting me to talk about characterization of renal masses with MRI. Unfortunately, incidence of renal cancer has increased by 30 to 40% over the last 30 years or so. And this is predominantly due to incidental lesions due to increased imaging with ultrasound and CT scan. Although most of these lesions are less than 4 centimeters, increase in diagnosis has not resulted in better clinical outcome. In fact, they reported increased mortality from 1.5 to 6.5 deaths per 100,000. And this is predominantly due to overdiagnosis and surgeries and aggressive management, even slow-growing tumors, which may or may not show growth over the time. The cost-effective strategies are necessary, especially to identify the clinically significant renal masses that could evolve into life-threatening disease versus the overtreatment of benign or indolent malignant lesions that can be observed. As we know, ultrasound is very cost-effective. It is very diagnostic for simple cyst. However, it has its limitations with smaller lesions. Patient's body habitus characterized in complex cystic masses, differentiating from complex cystic masses to solid lesions, and cannot stage the disease. CT scan is very sensitive and specific for renal masses for greater than 2 centimeter in diameter. However, it does have its own limitations in complex cyst containing hemorrhage of protein, lesion size, intraparenchymal lesions that cannot be measured accurately as far as Hounsfield density is concerned because of volume averaging and misregistration artifacts. It can be limited with renal function. So that's where MR comes in. MR has got excellent soft tissue contrast, due to which we can use multiple sequences and parameters to characterize the renal lesions. We do not need iodinated contrast, so some of the patients who have allergies can be still scanned with this. In cases of renal insufficiency, now with newer microcyclic agents, we can give IV contrast even in end-stage renal failures. My learning objectives for this talk are to discuss typical and variable features of common renal tumors, how MRI can help as a problem-solving tool to characterize the renal lesion, by which the clinical management, planning intervention, and avoiding unnecessary procedures. The plan for today would be to talk about different types of tumors, how we can characterize those with MRI. I'm not going to discuss potpourri of all renal masses. I'm not going to talk about inflammatory or pseudorenal masses or cystic lesions. We are going to briefly talk about renal cell carcinomas and its subtypes, some typical and atypical AMLs, oncocytomas, and other tumors. First of all, technique. Technique is very important. Our MR protocol is same for all abdomens. It has coronary T2, axial T2 fat sat, gradient echo, in and out of phase imaging, DWI, and coronal and axial Dixon. Post contrast, we typically do all these sequences in with post contrast images in arterial, venous, 3-minute delay, 5-minute delay in coronal, and for all we do subtractions as well. The money sequences that can really make difference in diagnosing renal as well as liver lesions is subtraction, in and out of phase, and fat sat. Remember that for renal tumors, fat is your friend, and diffusion weighted images. As far as subtraction technique is concerned, it is grossly underutilized. It drives me crazy when I see outside scans where subtractions is not done. This is very simple. You just have to push a button and machine does it for you. There is no extra table time or patient time. I think it's crime not to do subtraction sequences when it is so easily available, and it makes a lot of difference in characterizing these lesions. So essentially in this, you are subtracting pre-contrast images from post-contrast images. So it will subtract out the hemorrhage, hyperintensity within the lesion, and it will just give you pure enhancement within the lesion, which helps you a lot. So for example, in this patient, this is a lesion with slightly hyperdensity. There's peripheral calcification following intravenous IV contrast. There is no way of measuring how much this lesion is enhancing. Same thing with MRI. You can see on T2-weighted images, it is hypointense. So this is a cystic lesion. On pre-contrast even, it is markedly hyperintense, indicating hemorrhage or proteinaceous material with IV contrast. You cannot exactly determine whether this is contrast or the hemorrhage within the lesion, but when you do subtraction, you can see this ugly nodule within this cyst, which was a papillary renal cell carcinoma, which would have been difficult to diagnose either on the CT images or non-contrast or non-subtracted images. So subtraction technique is very important. Another lesion here on CT scan without contrast, arterial phase, portal venous phase, or nephrographic or corticomedullary and nephrographic phase. We don't know whether this lesion is enhancing or not, but on MRI, you can see that on T2-weighted images, there is some heterogeneity within the lesion. On pre-contrast images, there is area of hemorrhage, but with IV contrast, we don't know how much of it is enhancing. On subtraction, you can clearly see that it has got low-level enhancement. This was another papillary renal cell carcinoma. This was a 50-year-old patient, shows an ugly-looking bilobulated lesion with hyperintensity on T1 pre-contrast weighted images. Even on T2 weighted images, the lesion looks extremely ugly, but with IV contrast, you don't know whether this lesion is enhancing or not, but on subtraction images, you can clearly see that this is just a hemorrhagic lesion. There is no abnormal enhancement within it. We followed this lesion for 3 years, and you can see that there is hardly change in this lesion. There's still some hemorrhage. It is still looking ugly, but there is no enhancement on subtraction images, which saved nephrectomy for this patient. This was a high-grade papillary renal cell carcinoma. You can see that this lesion has got extensive hemorrhage within the lesion. This area, we don't know what is happening with IV contrast without subtraction. We don't know whether this area is enhancing or not. And on subtraction images, you can see really ugly-looking papillary renal cell carcinoma, which can be easily diagnosed once we subtract that hemorrhage. So subtraction, very important for diagnosing tumors. How about in and out of phase imaging? This is especially diagnostic for angiomyolipomas and some of the clear cell renal cell carcinomas. Let's see how we can diagnose those. Angiomyolipomas come in different flavors. They can be very fatty, like this, where you are going to get this India ink artifact at the fat water interface, and this is diagnostic of angiomyolipoma. You can also see that there is fat here, which is going to suppress on fat sat images. Another lesion, intraparenchymal angiomyolipoma, is going to show that India ink artifact all around it, as well as chemical shift artifact. Some of the lesions could be tiny, which will completely show dropout on out of phase imaging. If there are lesions containing less fat, then that portion of the lesion is going to show a drop on out of phase imaging. However, the problem comes when there is a lipid poor AML or clear cell carcinomas on in and out of phase imaging. However, it has been shown that the lipid poor angiomyolipomas tend to follow signal of psoas muscle on in phase, and they will show areas of drop in signal on out of phase depending on how much fat content is within the lesion. Whereas in renal cell carcinoma, They usually follow the parenchymal intensity on in phase, and on out of phase, due to intracytoplasmic fat, that is microscopic fat, is going to show uniform drop in signal, which is very characteristic of clear cell renal cell carcinoma. This is a clear cell renal cell carcinoma in phase, out of phase. Although this tumor looks slightly heterogeneous, you can see that on out of phase imaging there is uniform drop in signal, and that's because of intracytoplasmic fat seen in this lesion, which is very typical. In lipid poor angiomyolipoma, again, we can see that it follows the signal of psoas on in phase. On out of phase, there are areas of drop in signal within it due to this small fatty tissue within the lesion, but it really depends on how much fat is within the lesion. This is lipid-rich angiomyolipoma, which follows the signal of surrounding fat. You can see it is getting saturated on fat set sequences, and out of phase imaging, it shows areas of drop in signal, typical for lipid-rich angiomyolipoma. How about diffusion ADC sequences? This is especially helpful in differentiating cystic benign lesions from cystic renal cell cancers, can differentiate benign from malignant renal tumors, may be helpful in differentiating histologic subtype or grading the severity of the tumor. DWI is also useful in patients if you cannot give gadolinium, and that might be your only chance to grade the tumor. So here is a low-grade, this is oncocytoma, which shows hardly any restriction, whereas this is a clear cell renal cell carcinoma. You can see how much restriction is there and low ADC. So very helpful. This is a busy chart, but let's tease it out. The RCC subtypes are clear cell, which is by far the most common, papillary, and chromophobe. It's important to differentiate between these three, as clear cell carcinoma tend to be very aggressive depending on its grade and stage and sarcomatoid changes. And one needs to be very aggressive in treating these tumors with nephrectomy, whereas papillary and chromophobe tend to be relatively slow growing, especially chromophobe. It has got 5-year survival of 80 to 93%. The management could be different here. In papillary and chromophobe, you could be you can do nephron sparing surgery, which will help in preserving renal function depending on patient's age. So very important to make sure the type of tumor which you may be able to do with MR. There are 4 things that you can look to characterize this renal cell different types of renal cell carcinomas. One is T2 signal, in and out of phase, type of enhancement, and whether there is necrosis or cystic changes within the lesion or not. So depending on this, we can see that in clear cell type renal cell carcinoma, on T2 weighted images, the lesion tend to be very high or intermediate in signal intensity compared with low intensity on papillary renal cell carcinoma and intermediate signal intensity on chromophobe type. On in and out of phase imaging, since clear cell renal cell carcinoma has got that intracytoplasmic fat, it's going to show drop in signal, usually uniform on out of phase imaging, which we saw earlier. Whereas in papillary renal cell carcinoma, there is drop in signal on in phase, not out of phase, but in phase. That's due to hemosiderin or hemorrhage within the lesion. Whereas chromophobe type is usually homogeneous. As far as enhancement is concerned, clear cell type shows avid enhancement, which is similar to the cortex of the lesion, whereas papillary shows minimal enhancement and chromophobe shows mild to moderate enhancement. Clear cell carcinomas tend to have necrosis within it. Papillary type may show some small cystic changes, and chromophobe tends to be uniformly solid without any necrosis or cystic changes. So on arterial phase, you can see here that this is the clear cell type renal cell carcinoma, which is showing avid enhancement similar to the cortex. There are areas of necrosis within it. This is partially exophytic, more than 3 centimeter at the diagnosis, whereas papillary is relatively hypovascular. You need subtraction images to see the mild enhancement. It is fairly well defined. And chromophobe, it shows mild to moderate enhancement, well-defined, no necrosis within the lesion. So how does CT and MR perform in characterizing intermediate renal lesions? Margulis and his group performed a retrospective study of 143 patients with indeterminate renal lesions detected on ultrasound. 77 had CT, 66 had MRI, and MRI showed definitive diagnosis in 95% of patients versus 78% on CT scan. MRI recommended only additional studies or recommendations such as follow-up only in 1% of patients, whereas CT recommended more than 10% additional evaluation. So MRI was more likely to give definitive diagnosis and less likely to recommend further imaging than CT. So let's go through a couple of scenarios to run through different types of tumors and where MR is going to be helpful in diagnosing these lesions. So scenario 1, MR can be helpful to further characterize lesion where initial CT protocol was not adequate. So this patient had CT scan without contrast, and you can see that this patient has got multiple renal lesions, except one. Probably rest of the lesions are not characterized on this non-contrast CT scan. You can go ahead and do CT protocol with arterial venous phase. However, still there are going to be some lesions which are not going to be characterized. As you can see on this MRI, that all these lesions look cystic. Some of this lesion, for example, this one is hemorrhagic lesion. There's small hemorrhagic lesion here, which would have been a problem with CT scan with and without contrast. But on MRI, we can show that all these lesions are benign, and this patient does not need a follow-up or any other study. MRI in this patient had CTA examination, which showed an indeterminate lesion here. We went ahead and did MRI in this patient, and we can see there's this lesion which was not characterized on with contrast is in fact an angiomyolipoma. We detected another angiomyolipoma here. These two lesions showed gross fat within it. So there was no additional examination necessary in this patient. Summarizing scenario 1, MR can be helpful to further characterize lesions which are where the initial CT scan protocol was not adequate. So let's see whether MRI can be helpful in indeterminate lesion despite of adequate CT protocol. So here the protocol is adequate, but still the lesions could be non-diagnostic because in homogeneous lesion, if there is intermediate change in density, that is increase in density less than 20 Hounsfield unit, but more than 10 Hounsfield unit, then those lesions are going to be indeterminate. Whereas if it is a heterogeneous lesion, then it's going to be difficult to exclude smaller nodular areas within the lesion. So this is a renal mass or renal lesion here. You cannot see it on pre-contrast, but there was 90 Hounsfield unit increase in density from pre-contrast to post-contrast, which is non-diagnostic. So this is indeterminate lesion. We also have to remember that smaller cysts, which are intraparenchymal in central in location, can give false reading because of partial volumic artifact for those smaller lesions within the renal parenchyma. In this patient, we went ahead and did MRI, and we can see that on T2-weighted images, it's a cystic lesion. There's some internal density on pre-contrast T1, but however on post-contrast images as well as on subtraction, there is no enhancement. So this is a lesion containing mild hemorrhage. So advantage of MRI in such patients is we don't have to worry about pseudo enhancement. We have subtraction images to subtract out the protein or hemorrhage within the lesion. And we got very sensitive fluid sequences, which can help us diagnosing these cystic indeterminate lesions. There was this study done for potential renal donors, which is very important because we don't want to transplant any kidneys with renal lesions. There were 105 lesions, which were with average size of 1.5 centimeter. 94 patients, all these patients had CT scan with subsequent MRI. On CT scan, 94 of these 105 lesions were TSTC, that is too small to characterize by a CT. When they did MRI, in 99% of the lesions, MRI was diagnostic and no further imaging was necessary, out of which 83 were simple cysts, 8 were proteinaceous or hemorrhagic cysts, 2 were AML. So take-home point is MR can characterize small lesions that are indeterminate with CT due to pseudo-enhancement or partial volumic artifact. This was an indeterminate lesion. As this lesion was kind of bilobed or trilobed, and we can see following administration of IV contrast, you can see some septations within it. Is there some nodularity within it? So this was at least 2F lesion by Bosniak classification. On MRI, we can see this portion of the cyst has got dense hemorrhage. The other portion of the cyst did not have any hemorrhage, and is an enhancing nodule, which was diagnostic of early cystic renal cell carcinoma in this patient. So MR is sensitive for detection of enhancing nodules in cystic renal lesions. It upgraded 73% of patients on this study. It had 95% positive predictive value for malignancy with enhancing mural nodules. How about lesions with low enhancement that is difficult to detect on CT scan? The solid mass, which is most likely to result in this conundrum, is papillary renal cell carcinoma. As we can see it here, this is the enhancement pattern of clear cell renal cell carcinoma, chromophobe type, and papillary type. And papillary type, you can see it shows very low enhancement with IV contrast compared with other two tumors. So if you suspect that there is very low enhancement, or rule of thumb is if you have difficulty in deciding whether it is enhancing or not, they consider it to be a papillary renal cell carcinoma, because in up to 30% of patients with CT, this enhancement is undetectable. These lesions tend to be hyper dense on pre-contrast CT, so it's difficult to measure the enhancement in many of these patients. This is a patient with looks like hemorrhagic cyst with IV contrast, and on pre-contrast images, the density was around 28 Hounsfield units. Following IV contrast on corticomedullary and nephrographic phase, there was enhancement of 16 to 17 Hounsfield units. So this was, although the lesion size is pretty large, it was still indeterminate. Whereas on MRI, you can see that this lesion it has intensity similar to parenchyma with IV contrast. You can clearly see that there's some enhancement, which on subtraction images, we can clearly see that this is a solid enhancing lesion, which was papillary renal cell carcinoma. So over half of the papillary renal cell carcinoma did not show definitive enhancement on corticomedullary phase with CT. On nephrographic phase, it did show some enhancement. So nephrographic phase is probably the best phase, but MR did not have any problems detecting these lesions at all. So take-home point is when reading CT scan for hyperdense lesion, nephrographic phase is key, although you are still going to call some indeterminate lesions with this. MR has better sensitivity and specificity for detecting enhancement of low level enhancing lesions versus hemorrhagic cyst in these patients. Scenario number 3, how about CT protocol is adequate? Lesion is enhancing, but the diagnosis is uncertain. So in this, the lesion is not fully evaluated with CT scan. For example, this patient, which was a fat poor AML, but based on multiple sequences and enhancement pattern and diffusion weighted images, as well as in and out of phase images, MR can characterize many of these lesions. For example, this is a clear cell carcinoma. This is probably typical. It shows with areas of necrosis within it. There shouldn't be any problem in diagnosing this on CT or MR. We can see that on nephrographic as well as corticomedullary phase, it's going to show marked enhancement, especially in corticomedullary phase. It is going to show a drop in signal, as I showed you before, on out of phase imaging, which is going to be uniform due to intracytoplasmic fat, which is also pretty helpful. Whereas in papillary renal cell carcinomas, which is second most common, they tend to be very cellular. They are hypointense on T2 weighted images. These are relatively indolent lesions, so it's important to separate this out from renal cell carcinomas. These tend to be bilateral and are more common in renal failure patients. Here, in this patient, there are multiple lesions. You can see one lesion on right side, which shows typical appearance of papillary renal cell carcinoma, which is low enhancement, and it is low signal intensity on T2 weighted images, whereas this lesion, we could see another lesion in the other kidney, which had similar features, whereas third lesion, which was there, was a simple renal cyst. So with help of MRI, we can easily diagnose papillary renal cell carcinoma, which may be indeterminate on CT scan. And you don't have to have aggressive treatment in these patients, depending on patient's renal function, age, and everything. You can do some other type of treatment. So papillary renal cell carcinoma commonly involves end-stage kidneys, often contain hemorrhage or cystic degeneration, usually homogeneously hypoenhancing. They can show some restriction on diffusion-weighted images due to their cellularity, which doesn't help. But unlike clear cell RCC, papillary renal cell carcinoma is frequently hypointense on T2-weighted images, whereas the clear cell type, there are hyperintense on T2-weighted images. This is one of the ugly-looking papillary renal cell carcinoma. We can see that it is hypointense on T2-weighted images compared with clear cell, which are going to be hyperintense. On T1-weighted pre-contrast images, we can see some hemorrhage. We don't know what is happening here, but on subtraction images with IV contrast, you can see multiple lobulations, fronds, along the surface of this lesion, indicating aggressive type papillary renal cell carcinoma. How about chromophobe? This is probably the least common and more indolent type of low-grade tumor. It shares morphologic features and histologic features of oncocytoma. They tend to be ISO to hypointense on T1 weighted images. They show mild enhancement with IV contrast, no necrosis. Their enhancement pattern is less than clear cell carcinoma. So they are something in between. So rule of thumb in these lesions is there are usually slightly hypoenhancing compared with the cortex. There can be diagnostic challenge in diagnosing oncocytomas. However, with MRI, there are certain features which can be diagnostic. These tumors tend to have central scar. They tend to be slightly hyperintense, which is kind of unique for oncocytoma. They are slightly hyperintense on T2 weighted images, and they show kind of slightly spoke wheel type of enhancement with IV contrast in corticomedullary phase. And on the nephrographic phase, they tend to be slightly hypointense. The another unique feature of these tumors is the scar doesn't enhance initially, but on delayed imaging, the scar will show enhancement, which will help you differentiate between the renal cell carcinoma and oncocytoma. The central scar, hyperintensity on T2 of central scar, delayed and complete enhancement. Now, intravoxel fat that is on out of phase is not going to show low intensity, was 97% specific and 55% sensitive in patients with oncocytoma versus renal cell carcinoma based on these two studies. So very powerful feature to differentiate this from clear cell type renal cell carcinoma. Another feature that has been described is segmental enhancement inversion in oncocytomas. So on corticomedullary phase, some portion of the tumor may enhance, which gets washed out, and then the other portion of the tumor will enhance on nephrographic phase, which is kind of unique for oncocytomas. We often have diagnostic challenge with fat-poor angiomyolipomas. Fortunately, these tumors tend to be, the percentage of these tumors is less. Whenever there is less than 25% of fat per high power field on path, they call it fat-poor angiomyolipomas. The key MR features in these patients is they are dark on T2. Unlike renal cell carcinomas, which are going to be high on T2, they do show restricted diffusion, which is a problem, but they do not show any necrosis. And they might show some areas of drop in signal on out of phase, depending on how much fat is within the lesion. Sometimes you may not be able to distinguish this from malignancy, and there is no shame in doing biopsy in these patients. Actually, this study was just published last month, which showed that if you see actually lipid-poor angiomyolipomas on T2-weight images show this uniform low signal, and they show moderate enhancement on corticomedullary phase, and this is actually 80. This is diagnosed. Actually, this was kind of very useful feature in diagnosing lipid-poor angiomyolipomas. This was seen in 83% of patients with. The sensitivity was 83% and specificity was 90% in this patient. So maybe this feature is going to be very useful in diagnosing lipid-poor angiomyolipomas. Sometimes on CT scan, although with naked eye, you might say that there is fat within this lesion, but when you actually measure those because of increased density from vessels, you might not get typical fat measurements. In those patients, MR is also useful because here you can see that this lesion is clearly has similar intensity as surrounding fat. It has got India ink artifact at fat fluid interface, and shows some enhancement with IV contrast. So MRI confirms AML. Sometimes you might be able to see this pushing of fat into the renal parenchyma, which is typical for angiomyolipoma from where it arises. So pretty diagnostic if you see it. So how about MR versus CT characterizing renal masses? This group did a study of 120 patients in lesions which were indeterminate on CT followed by MRI. The final diagnosis was based on pathology or follow-up. 39% of these lesions were benign masses such as angiomyolipoma, oncocytoma, or hemorrhagic cyst. The sensitivity of CT for diagnosis of renal cell carcinomas was 91% versus MR, it was 94%. Specificity for CT was only 28%. Remember, these are indeterminate lesions, whereas with MR, it was 68%. So using MRI in approximately 12.5% of patients, with malignant diagnosis on CT could have avoided surgery, whereas 2.5% of benign diagnosis on CT would have been appropriately recommended surgery, which was not done with CT scan. So another study which was published in Abdominal Imaging, which had 63 patients with indeterminate lesions, which were smaller than 2 centimeter. And of these 63 patients, MR was sensitive 100% of the time. That means it diagnosed all those 63 patients. MR was 95% specific, indicating benign versus malignant lesions. Of these 63, only 3 remained indeterminate following MRI. So MR take-home message is MR is great, has greater specificity than CT in distinguishing benign versus malignant diagnosis, and fewer lesions remain indeterminate after MRI. So wrapping up, MRI is indicated in evaluation of indeterminate renal masses on CT and ultrasound and provide additional diagnostic information which can be helpful in diagnosing and managing these patients. MR imaging is particularly helpful in distinguishing solid from cystic lesions when enhancement of renal masses is questionable, especially for those where net enhancement on CT is between 10 and 20 Hounsfield units. So we can either upgrade or downgrade Bosniak 2F lesions so that these patients do not have to go for follow-up examination every 6 months to 1 year for 2.5 to 3 years. Diffusion-weighted imaging and dynamic contrast enhanced imaging can provide specific information regarding tumor histology and staging. MR is especially useful for too small to characterize lesions. There are not going to be any lesions which are too small to characterize on MRI, lesions with low level of enhancement, hemorrhagic lesions, and complex cyst. And that's all from me. Thank you.
Everybody, it's a pleasure to be speaking at this MRI conference today. My topic here is congenital CNS anomalies. As you know, it's a very broad topic, and in the next 30 to 35 minutes, I'll probably barely scratch the surface. So for this case-based review, what I have done is I have focused on a few selected entities, and I will start with showing an uncommon presentation of that entity and use that as a launch pad for a general discussion on that particular condition. So let's get started. So the first case is a 15-month-old who presented with seizures. On the sagittal T1 weighted images, we can right away see absence of the corpus callosum, and then there are these multiple sulci which radiate all the way up to the ventricular margins. On the coronal images, there is absence of crossing fibers, abnormal ram's horn orientation of the frontal horns, a high riding and dilated third ventricle. Similarly, on the axial T2 weighted images, there is absence of crossing fibers in the midline with a prominent interhemispheric fissure. But the patient also has many other abnormalities, including these multiple cysts in the lateral ventricles and possibly in the interhemispheric fissure. You can also see those cystic structures on this sagittal T1 weighted image. Also, the cortex and the gyral contours are very abnormal, with broad gyri and shallow sulci in the right frontal region associated with this large mass-like area of gray matter heterotopia. So what is this constellation of findings called? Is it Aicardi syndrome? Is it Aicardi-Gutierrez syndrome? Is it glioneuronal tumor based on the cystic changes? Or is it Miller-Dieker syndrome? So this appearance is diagnostic of Aicardi syndrome. So Aicardi syndrome is one of the syndromes associated with corpus callosal dysgenesis, and it has the associated findings, as we saw, including gray matter heterotopia, polymicrogyria, cysts, and sometimes posterior fossa anomalies as well. It is a rare developmental disorder which is caused by an X-linked defect, so it is fatal in males and only manifests in females. Clinically, it is characterized by infantile spasms, and on fundoscopic exam, you may see chorioretinal lacunae. A few words about corpus callosal dysgenesis. So corpus callosal dysgenesis is one of the most frequent brain malformation. It can be complete absence of corpus callosum, which is called agenesis, or partial absence or dysgenesis. It is often associated with genetic abnormalities, either trisomies or some single gene mutations, or can be associated with extrinsic factors like maternal alcohol syndrome. As you know, corpus callosal dysgenesis is often associated with other intracranial and spinal anomalies or craniofacial anomalies, and a lot of them have syndromic associations. This is a companion case. This is a 17-year-old male with developmental delay and seizures. On the axial T2 and T1 weighted images, we see this lobular hyperintense mass in the midline in the expected location of the corpus callosum. Also, there is parallel orientation of the lateral ventricles. On the sagittal T1 weighted images, we see this lobular T1 hyperintense mass in the region of corpus callosum, which completely suppresses on fat-saturated sequence. This is an enhancing vessel through that region. So the findings are suggestive of a pericallosal lipoma with dysgenesis or absence of corpus callosum. So pericallosal lipoma, it's the most common location for an intracranial lipoma. It occurs in the interhemispheric fissure, and it is closely related to the corpus callosum, which is often malformed. There are two morphological subtypes of pericallosal lipoma, which include a tubulonodular, which is the more common, like in our case, and it's often associated with severe corpus callosal dysgenesis. The other subtype is curvilinear, where you have a thin band of fat along the corpus callosum, and the corpus callosum may be either normal or only mildly dysgenetic. There can be other associations with this, including absence of pellucidum, azygous ACA, polymicrogyria, heterotopias, or sometimes dorsal cysts. Moving on to case number 2. This is a 1-month-old child with dysmorphic features. So on the axial T1 weighted images, we see this abnormal fusion of the cerebral hemispheres across the midline. The interhemispheric fissure is partly present. It's present anteriorly, and a small portion is present posteriorly, but it's obliterated in the midline. And you can see the continuation of gray matter and white matter across the midline, as well as these abnormally long sylvian fissure, which continues across the midline over the vertex to extend onto the contralateral side. Same findings on the coronal images. There is fusion of the cerebral hemispheres in the midline. There is fusion of the ventricles with absent interventricular septum. And on the sagittal T1, so what's the diagnosis here? Is it schizencephaly? Is it scintillencephaly? Is it semilobar holoprosencephaly? Or is it arhinencephaly? So this is an example of scintillencephaly, which also goes by the name of middle interhemispheric variant of holoprosencephaly. So what is holoprosencephaly? So holoprosencephalies are characterized by incomplete separation of hemispheres due to abnormal cleavage of the prosencephalon. It's often associated with other midline anomalies, including anomalies involving the corpus callosum and the hypothalamic pituitary axis, and also associated with craniofacial malformations. Holoprosencephaly is a spectrum, with the least severe form being alobar and with the most severe form being alobar and the least severe being lobar. Middle interhemispheric variant is somewhere probably between semi-lobar and lobar. So in alobar holoprosencephaly, there is a single midline forebrain with a horseshoe-shaped monoventricle and a dorsal cyst. In semi-lobar holoprosencephaly, there is some separation of the hemisphere. The interhemispheric fissure is partly present posteriorly, and there is fusion anteriorly. There is variable degree of deep nuclei and thalamic fusion in semi-lobar. And lobar holoprosencephaly is the least severe form, where there is only fusion of the most inferior portion of the frontal lobes. Otherwise, the hemispheres are separated. So this particular case is the middle interhemispheric variant of holoprosencephaly, which is a relatively milder form, and there is cerebral fusion in the posterior frontal or the parietal region with partial presence of interhemispheric fissure anteriorly and posteriorly. There is a horizontally oriented sylvian fissure that extends across the midline over the vertex. The corpus callosum is usually abnormal, with the body being absent and the genu and splenium are present. So holoprosencephaly are kind of the exception to the rule of callosal dysgenesis in terms of its embryological development. This is an example of semilobar holoprosencephaly, where you see fusion of the frontal lobes across the midline. There is absence of interventricular septum, but the interhemispheric fissure is partly present posteriorly. Again, you can see the same findings on T1 weighted images. There is this band of gray matter along the anterior aspect of the ventricles, absence of the interventricular septum, and fusion of the frontal lobes across the midline. On the sagittal images, we can see absence of the corpus callosum in the mid portion, although a portion of the splenium and probably the genu are present. This is an example of alobar holoprosencephaly, where there is lack of separation of the cerebral hemispheres. There is a single forebrain with a horseshoe-shaped monoventricle, which widely communicates with this large dorsal interhemispheric cyst. Moving on to case number 3, this is a child who presented with seizures. So on MR evaluation, we have coronal and sagittal T1 MP-rate sequence. So on these T1 weighted images, we see this abnormally thickened and lobular appearing cortex in the right perisylvian region as well as in the left perisylvian region. Also on the sagittal images, we see this abnormally deep sylvian fissure, which extends all the way up to the vertex and is lined by these thickened and lobular appearing cortex. Same findings on T2 weighted images. You see abnormally thickened and lobular cortex in bilateral perisylvian region. Also, there is absence of septum pellucidum. So what's the diagnosis? Is it schizencephaly, polymicrogyria? Is it focal cortical dysplasia type 2, or is it gray matter heterotopia? So this is an example of bilateral perisylvian polymicrogyria. So polymicrogyria is characterized by numerous small gyri with bumpy appearance of the gray-white contour. It is caused by derangement of neuronal organization and abnormal cortical lamination. It can be sporadic or can be genetic, or sometimes may be associated with in utero infection or vascular insults. There are multiple syndromic associations with polymicrogyria, and on imaging, it can be focal, multifocal, or diffuse. So bilateral perisylvian polymicrogyria is one of the common presentations. It can be sporadic or familial. It presents with developmental delay, motor deficits, and sometimes seizures. There is a MR grading system for perisylvian polymicrogyria. So grade 1 is the most severe, where you have involvement of perisylvian region as well as frontal or occipital lobes, and the abnormality reaches all the way up to the frontal or occipital poles. Grade 2 is where the polymicrogyria extends into the frontal or occipital lobe but does not reach the poles. Grade 3 is purely insular and opercular region involvement, like we saw in our case. And grade 4 is the least severe form, where you have involvement only of the posterior insula bilaterally. So these are two cases showing focal polymicrogyria. So the patient on the left side has this almost mass-like lesion in the left frontal lobe with multiple lobular areas of gray and white matter. So this is an example of a complex nodular polymicrogyria, which can mimic a mass, but it does follow gray matter signal on all the sequences. This is another example of focal polymicrogyria, where in the left parietal lobe, we see an abnormally deep sulcus and a thickened lobular cortex lining the sulcus. So that can, again, this is something that can cause seizures and needs a careful evaluation of MRI for diagnosis. This is an example of diffuse polymicrogyria. A young child, a few months old, presented for presented with infantile spasms. So on the T1 and T2 weighted MRI, we see this abnormal gyral and sulcal pattern bilaterally. The gyri are abnormally wide, the sulci are shallow, and there is this nodular lumpy bumpy appearance of the gray white junction throughout. So this is an example of bilateral diffuse polymicrogyria. Moving on to case number 4, a 3-year-old female presenting with seizures. So on the axial T2 and T1 weighted images, again, we see this abnormal gyral and sulcal pattern. There is broadening of the gyri and very shallow sulci, and there is associated thickening of the cortex. If you look more carefully in the posterior region, there is this band of white matter which separates somewhat normal appearing cortex with this additional band of gray matter looking tissue. The finding is probably seen a little better on T1 weighted images, where we see posteriorly relatively normal thickness of the cortex, a band of white matter, and then another band of gray matter. Anteriorly, it looks more like diffuse cortical thickening. So what's the diagnosis? Is it polymicrogyria? Is it gray matter heterotopia? Is it focal cortical dysplasia type 2? Or is it agyria? So this is an example of subcortical band heterotopia. So subcortical band heterotopia belongs to the Lees-Cephaly spectrum of disorders. So Lees-Cephalies are characterized by smooth brain. There is paucity of gyri and sulci and associated thick cortex. It's on a spectrum. So agyria is the most severe form of Lees-Cephaly, where there is absence of a sulcation and the brain has a very smooth appearance with shallow sylvian fissures, giving it an hourglass appearance. The milder forms can be is called the pachygyria, where there is decreased number of gyri which are abnormally broad and shallow sulci. And pachygyria can be associated with subcortical band heterotopia. So Lees-Cephaly is caused by arrested neuronal migration, and the cortical lamination is abnormal with 4-layered cortex instead of 5. There are 2 important genes which are involved in Lees-Cephaly spectrum. The first one is the LIS1 gene. It's the most common. Either deletion of or mutation of this gene can result in Lees-Cephaly. The other is XLIS, or the DCX gene. It is it's an X-linked disorder which causes Lees-Cephaly in homozygous males, but it causes subcortical band heterotopia in carrier females. So our case was a 3-year-old female who had a pachygyria with subcortical band heterotopia. This is an example of what's called the classic Lees-Cephaly, where you have a smooth brain with diffusely thick cortex and very shallow sylvian fissure, giving it a figure of 8 appearance. This is another example of Lees-Cephaly, but in this case, there is associated microophthalmia and retinal detachment. So this constellation of finding is called the Miller-Dieker syndrome, and this is associated with LIS1 mutation. Another variant of Lees-Cephaly, which is sometimes called Lees-Cephaly type 2, is the cobblestone Lees-Cephaly. Again, just like any other Lees-Cephaly, there is reduction in normal sulcation, but in addition, there is a bumpy appearing cortical surface, which gives the name cobblestone Lees-Cephaly. This is commonly associated with the muscular dystrophy syndromes, which also go by the name of alpha-dystroglycanopathies. And these include conditions like Walker-Warburg, Fukuyama, and muscle eye brain disease. So on imaging, we may not be able to distinguish between these individual subtypes. So what we can call on imaging is a Walker-Warburg imaging phenotype when we have all of these findings present. So let's look at an example. So in this patient, we have this diffuse paucity of sulci in both cerebral hemispheres with a smooth appearing cortex, with a smooth appearing gyri, but there is this lobular morphology to the cortex. So that's characteristic of cobblestone Lees-Cephaly. You can see it a little better in the parieto-occipital regions. There is associated marked ventriculomegaly, and this characteristic kinked appearance of the brainstem with associated cerebellar hypoplasia. There may be some mild cystic changes in the cerebellum as well. This patient also has abnormalities of the eye in the form of persistent hyperplastic primary vitreous. So this constellation of findings of cobblestone Lees-Cephaly, callosal dysgenesis, ventriculomegaly, abnormally kinked brainstem, hyperplastic cerebellum, and ocular anomalies is associated with the Walker-Warburg phenotype. Next case is a 5-month-old who presented with nasal obstruction. So we have a sagittal T2 and T1 weighted image, which shows a bilobed mass extending into the nasal cavity. Superiorly, the mass appears to communicate with the subarachnoid space via a defect in the cribriform plate. Same findings on the axial and coronal images. And on the post-contrast images, there is enhancement of mucosa surrounding this cystic mass, but there is no enhancement within the mass itself. So pretty straightforward diagnosis. Is it a cephalocele, a nasal dermoid, nasal glioma, or an inverted papilloma? So the diagnosis in this case is a cephalocele. So cephalocele is congenital herniation of one or more intracranial structures through a defect in the skull. And depending on the contents, it could be a meningocele, which contains meninges and CSF, meningoencephalocele, or simply encephalocele, which contains meninges, CSF, and brain parenchyma. Cephalocele is a more general term, which includes both meningoceles and meningoencephalocele. And then there is a variation of cephalocele, which is called as atretic parietal cephalocele, which is typically seen in the midline hyparietal region and is characterized by herniation of meninges and some fibrous or dysplastic tissue. Location, it can occur in the posterior location, either in the occipital or occipitocervical region, and this form of occipital cephalocele is more common in the Western countries, or it could be frontoethmoidal, which is called the sincipital cephalocele, which is more common in Southeast Asia. So frontoethmoid cephalocele can also be classified into two types based on the bony defect. It could be nasofrontal, as in this case, where you have herniation between the frontal bone and the nasal bone, or it could be nasoethmoidal, where you have herniation between nasal bone and the nasal cartilage, like in our case. This is an example of occipital cephalocele. So we have a large bilobed cystic mass arising from this defect in the occipital bone. There may be some herniation of brain parenchyma through the defect. Intracranially, we see effacement of the extraaxial spaces, mild dilatation of the ventricles, and abnormal morphology of the posterior fossa structures, including a small posterior fossa, effacement of the cisterna magna, inferior herniation of the cerebellum, and crowding at the foramen magnum. So these findings are reminiscent of a Chiari-2 malformation, but when you have a cephalocele with findings similar to Chiari-2, it's called Chiari-3 malformation. So typically in Chiari-3 malformation, the cephaloceles are a little lower. They are in the inferior occipital or the occipitocervical region, but in our case, it was more in the superior occipital region. This is an example of a broad-based parietal cephalocele where there is a large bony defect in the parietal bone and herniation of both the cerebral hemispheres through the defect. There is also some gliosis in the herniated brain parenchyma. And this is an example of atretic parietal cephalocele. Like we previously said, it's most commonly seen in the midline parietal bone, and it's characterized by a herniation of meninges and some dysplastic tissue, but there is no herniation of brain parenchyma or dural sinuses. There's typically abnormal orientation of the straight sinus, which is more vertical. There is a persistent falcine sinus. And then there is this cigar-shaped CSF cleft, which extends from the supracerebellar cistern all the way up to the defect in the calvarium. And also in this case, on the MR venogram images, we see this focal defect in the superior or focal splitting of the superior sagittal sinus, which is related to where the tract bisects it to reach the defect in the calvarium. The next case is a spine case. This is a 1-month-old child who presented with a sacral subcutaneous mass. On the sagittal and axial T2 weighted images, we see dysraphism of the sacral region, and we see the cystic mass, which appears to be contiguous with the distal spinal cord. Here again, you can see the distal spinal cord with the cystic mass contiguous with it. There is no associated lipoma, although there is some continuity of the epidural fat with the subcutaneous fat. The important thing to note here is this is a closed defect, that the cystic structure is completely covered by skin and the subcutaneous tissues. So what's the diagnosis here? Is it a myelomeningocele? Is it a myeloschisis? Is it a myelocystocele? Or is it a dermoid cyst? So the correct answer here is myelocystocele. So myelocystocele is a closed neural tube defect where you have herniation of the dilated central canal or the syringocele through a defect in the posterior elements. Here is a diagram illustrating the myelocystocele. So you have dilatation of the distal dilatation of the spinal canal, which is called a syringocele, and the syringocele extends through a dystrophic defect in the posterior elements. And since it's a closed neural tube defect, the cyst is covered by skin and subcutaneous fat. So it's a rare form of closed or occult spinal dystrophism, presents with skin-covered subcutaneous mass, as in our case. It's most commonly seen in the sacral region, where it's called the terminal myelocystocele, although it can be seen in the cervicothoracic region, where it's called the non-terminal myelocystocele. This is an example of non-terminal myelocystocele, where we have this dilated central canal extending into this fluid-filled tract through a dystrophic defect in the upper cervical spine. So this is the meningocele component. So this is like a cyst within a cyst, and the outer cyst is the meningocele. And the inner cystic component, which is contiguous with the spinal cord, is the myelocystocele component. So I find this chart very useful, which classifies the neural tube defects. Neural tube defects can involve the cranium as well as the spine, but we are focusing on spine right now. So spinal defects can be open or closed. Open defects are associated with Chiari malformation and ventriculomegaly, while closed defects are not usually associated with intracranial findings. The two open neural tube defects which you need to remember is the myelomeningocele, which is by far the most common, or and the second is myeloschisis or myelocele. The most important closed neural tube defect, which will present with the skin-covered subcutaneous mass, is lipomyelomeningocele, and then you have the less common myelocystocele, like we saw in this case. So whenever you are evaluating someone with a neural tube defect, the first step is to identify whether it's a closed or open defect, and that will completely change your differential diagnosis. This is an example of lipomyelomeningocele, where you don't have a cystic structure, but you have a lipoma which is contiguous between you have a lipoma along the distal spinal cord, and it's contiguous with the subcutaneous fat. And again, this is a skin-covered defect. So this is an example of a fetal MRI with myelomeningocele. So these are this fetal MRI was obtained at 22 weeks of gestation, and this was obtained at 25-week gestation after a region with the large cystic structure. Or crowding at the foramen magna. So myelomeningocele is open spinal dystrophism. It's characterized by a low-lying spinal cord which ends in a neural placode, and the neural placode extends beyond the level of the skin surface, which causes expansion of the associated subarachnoid spaces. Intracranially, it's associated with Chiari-2 malformation and ventriculomegaly, like we saw in this case. In the recent year, our institution has done a lot of in utero repairs of myelomeningocele, and the data on that has been very encouraging. So the initial trial which established the efficacy of in utero myelomeningocele repair was done in 2011, the MOMS trial, and it showed that in
हाँ मित्र आवाज नहीं आ रहा है ना एक कुछ कर
Sorry, please bear with us. We just trying to sort out these technical problems. We'll put the link for the registration for the international edition of the MRI teaching course. So this starts on the 28th of October, 28th and 29th of October, and then we'll see you in November on the 3rd, 4th, and 5th. We'll be covering various sessions in AI, neuro, body imaging, MSK imaging, cardiac, as well as breast imaging. And we have an excellent team of international speakers who are joining us from US, Canada, UK, Singapore, Australia. We've already applied for MMC credit points, and there are some activities which we've also arranged. So case of the day is somewhere where you can send us your interesting or a rare case from your institute, and you'll be given a chance to present this during the conference. And the best entries will be receiving prizes for this. Also, you can send us your paper and poster submissions. You can mail them to mriteaching@gmail.com. All the submissions will be receiving e-certificates, and there are some prizes for the winners. So this is the excellent panel of speakers that we have who will be joining us for the conference. We have Dr. Scott Flam, who is a pioneer in cardiac imaging, who will be taking various topics, and Dr. Manohar Shroff, who is a professor and chair in pediatric radiology in CTBUZZ hospitals in Toronto. Very well known for his pediatric lectures. Then we have Dr. Thomas Link and Dr. Yagel Link. So there's a team of speakers from Mayo Clinic who will be joining us in October as well, and an entire day where Dr. Dushyant Sahani and his team of speakers will be taking various lectures throughout the day for us on 4th of November.
Gauri, I think we are ready with the lecture, so I will just share from my end.
Good morning, I'm Dr. Chaubal, and I'm going to speak about MR imaging of cholangiocarcinoma and its mimickers. So, I will discuss the imaging spectrum differential diagnosis of cholangiocarcinoma and the limitation of imaging of biliary strictures. So, cholangiocarcinoma is the most common primary biliary tract malignancy. It's second most common primary hepatic tumor after hepatocellular carcinoma. Seen worldwide, most common in North Thailand, where it is due to association with liver flukes infection, and it is seen twice more frequently in males compared to the. So these are the risk factors of cholangiocarcinogenesis: parasitic infection, as the liver flukes I just talked about, primary sclerosing cholangitis, cholelithiasis, biliary disorders like choledochal cyst, hepatitis B, hepatitis C, and cirrhosis, as well as lifestyle-related risk factors. I won't go into the details of cholangiocarcinogenesis. So these slides will be there in your PDF. So hepatitis B, hepatitis C, and liver cirrhosis, they are common risk factors for developing cholangiocarcinoma and hepatocellular carcinoma. So be aware of that. Many times clinician was the answer whether the patient with cirrhosis has cholangiocarcinoma or hepatocellular carcinoma. So that's the role of the radiologist become very good. So coming to the anatomical classification, the cholangiocarcinoma can be divided into peripheral intrahepatic cholangiocarcinoma, hilar intrahepatic cholangiocarcinoma extending from the insertion of the cystic duct to the second order bile duct, and then the extrahepatic cholangiocarcinoma as shown in this illustration. More important for us is to know the morphological classification of cholangiocarcinoma. These can be divided into mass-forming cholangiocarcinoma. So the mass-forming cholangiocarcinoma, they tend to invade into the liver parenchyma. They tend to obliterate the portal vein without invading into it. Whereas the second type, periductal infiltrating type, they tend to grow along the bile duct, so they usually present with long strictures and dilatation. The third type, the intraductal type, it grows into the duct as a papillary mass, expanding the bile duct. This one has the best prognosis. Why the morphology is important? Because it decides the tumor's behavior, surgical approach, clinical outcome, overall prognosis of the patient is decided by the morphology. Workup of the patient, biochemical workup, serum CA19-9 information is quite useful in differentiating the cholangiocarcinoma from hepatocellular carcinoma. As I said, that the patient with cholangiocarcinoma cirrhosis can go either way, either cholangiocarcinogenesis or they can develop hepatocellular carcinoma. But be careful, patient with benign biliary disease can also have high CA19-9. So the mass-forming cholangiocarcinoma, usually they are irregular mass, lobular mass with well-defined margin. In the periphery of the tumor, there are abundant tumor cells. In the central area, there are necrosis, fibrosis, and mucin. Hypointense on T1 and heterogeneously bright on T2 weighted image. Enhancement pattern is quite characteristic. In the arterial phase, they show peripheral thin rim of enhancement with progressive centripetal enhancement in the subsequent phases. And the delayed phase, there is more intense enhancement. They are predominantly hypointense on the hepatobiliary phase. And I'll talk more about it, some interesting signs on the hepatobiliary phase. The ancillary features are quite useful sometime in differential diagnosis. As I mentioned, the cholangiocarcinoma tend to encase the portal vein instead of invading as a tumor thrombus. They may be associated with biliary dilatation, lobar atrophy, capsule retraction, and some other ancillary features. This is a very interesting sign, cloud sign. So this is seen in patients with cholangiocarcinoma in the hepatobiliary phase. So the central area of the tumor is bright in hepatobiliary phase, and the periphery is hypointense. That is called cloud sign. Here is an example of a cloud sign which we reported in this journal. But this is not specific for cholangiocarcinoma. It can be seen in metastasis from the mucinous tumors. Another sign is a target sign, which is more specific sign of cholangiocarcinoma. So in the high B value diffusion weighted images, there is bright signal here because of the tumor cells, whereas in the center area, there is dark signals because of the fibrosis or necrosis. This is seen only in the high B value images. This is quite useful sign practically to differentiate small hepatocellular carcinoma from the cholangiocarcinoma. So this is seen in the cholangiocarcinoma. So first case here, T2 fat sat images show a heterogeneous mass on in the liver, and it shows heterogeneous T2 bright signals. The central area is more bright, the periphery is not so bright. In the high B value images and ADC images, clearly there is a cloud sign, so there is darkness only in the periphery of the tumor, and in the central area is more of a T2 shine through effect. So this is it's a target sign is present. The tumor is hypointense on T1 white images. In the arterial phase, classical peripheral rim-like enhancement. And in the venous phase and 3-minute and 5-minute delayed phase, there is progressive enhancement. See, the enhancement in this area becomes more dense with the time lapses. And in the hepatobiliary phase, what we are seeing is classical cloud sign. So this is how a cholangiocarcinoma looks like, classical cholangiocarcinoma. Everything specific is present about it in the cholangiocarcinoma. Sometimes even a single image is quite diagnostic of cholangiocarcinoma. So I'm showing that this is a patient who has a mass which is showing heterogeneous enhancement. There is peripheral capsular retraction. There is attenuation of the portal vein. It's not invaded. See, there is compression of the portal vein. There is associated peripheral ductal dilatation. So one image, quite confidently I can say that this is probably most likely cholangiocarcinoma. Another example, a 58-year-old man with hepatitis B and cirrhosis. CT scan shows in the portovenous phase a mass here. So the question again, whether this is cholangiocarcinoma or hepatocellular carcinoma. MR throws a lot of light on this case. Let's see that MR of this patient. So on T2 fat sat images, the mass is heterogeneous, mildly bright in the periphery and dark in the center. And on the diffusion weighted images, it's bright I'm not showing the ADC because of the lack of space here on my slide, but it was dark on ADC, so there is restricted diffusion. Look at this component of the mass. It is extending into a tubular structure, either it's a portal vein or it is a duct. So see that it's bright, it's behaving same as a primary mass. On T1 weighted images, this mass is hypo-intense. In the arterial phase, there is barely any enhancement in the mass, but there is some heterogen enhancement, very mild enhancement in the mass. In the venous phase and the delayed phases, there is progressive and more denser enhancement in the mass, as well as this component which is extending here. So this is extending here. There are ancillary feature here. The duct is dilated here, and there is capsular retraction. HepatoBiliary phase, the mass washes out, and if you move more caudal slices, this component which we were analyzing is not going into the portal vein, and the portal vein is here on this side, and the mass is here, and it's actually extending into the right duct. So all these features are favoring a diagnosis of cholangiocarcinoma. So quite comfortably, I can tell my clinician that this is not hepatoma, this is cholangiocarcinoma. Differential diagnosis, as I said, in clinical practice, is quite is a common query how to differentiate a cholangiocarcinoma from hepatocellular carcinoma. So this is a chart I got it. In my experience, this presence of fat is quite useful. When the fat is present, it's more likely hepatocellular carcinoma, because I have not seen fat really in cholangiocarcinomas in the literature they have described, though. Then the capsule in the delayed phase is seen in cholangiocarcinoma, in the hepatocellular carcinoma, and not in the cholangiocarcinoma. Diffusion weighted images, as I mentioned, there can be target-like appearance, which when it's present is quite useful. Portal vein involvement is typically in hepatocellular carcinoma, there is tumor thrombus, whereas in cholangiocarcinoma, there is encasement of the portal vein rather than tumor extension. Then the duct may be dilated in cholangiocarcinoma, whereas in only large hepatocellular carcinoma, the ducts are dilated. Another example, a 54-year-old man with hepatitis B. Again, the question is same whether this is a hepatoma or cholangiocarcinoma. MRI, let us see the MRI, what it shows. So on MRI, this lesion is mildly bright, but quite well demarcated on T2 fat sac images. There's a lot of information in the T1 weighted images. So in the out of phase image, the tumor looks more darker. There is signal loss, suggesting that there is fat inside the mass. And this is bright on high B value images. And I'm not showing the diffusion, but it was dark on diffusion, so there was presence of diffusion. And in the arterial phase, there is very mild enhancement compared to the unenhanced wipe images, not the typical enhancement pattern of hepatocellular carcinoma. But what is interesting is that in the 3-minute delayed phase, in the hepatobiliary phase, there is a peripheral capsule formation. So we have two evidence toward hepatocellular carcinoma. And then the further evidence comes from the biochemical workup of the patient. The patient's alpha fetoprotein level was more than 400, whereas the CA19 was not high. So comfortably, we gave a diagnosis of hepatocellular carcinoma. This tumor was resected, and the final diagnosis was well-differentiated hepatocellular carcinoma. A rare differential diagnosis of mass-forming cholangiocarcinoma is hemangioma, not the classical hemangioma, but the sclerosing hemangioma. The classical hemangioma typically has peripheral nodal enhancement in the arterial phase, and which moves centripetally. Whereas in the sclerosing hemangioma, the same findings are present, but they are delayed. So in the arterial phase, there is nothing, but in the venous phase, there is peripheral nodal enhancement, and even in the quite late phase, there may not be complete filling up of the tumor, of the hemangioma, because of the fibrosis element present in the center of the hemangioma. So in the clinical practice, again, it becomes sometimes difficult. This key is helpful. The hemangioma, they don't show any restricted diffusion. The bile ducts are never dilated in the presence of hemangioma. HepatoBiliary phase is not that useful. So here's an example here. 41-year-old man with incidental lesion in liver on the ultrasound, and the CT scan single phase photovenous phase shows there is a lesion with a heterogeneous enhancement in the periphery of the right lobe of liver. MR was done for this patient. On fat T2 weighted images, the lesion is heterogeneous, on slightly bright in the periphery but dark in the center. In phase, out phase, at least confirmed there is no fat, so unlikely hepatocellular carcinoma or no clue for hepatocellular carcinoma. There is no restricted diffusion, quite useful evidence. And in the arterial phase, there is no enhancement. In the venous phase, there is peripheral mild enhancement. In the delayed phase, there is centripetal moving of contrast. And finally, in the 10-minute delayed phase, the lesion completely enhancing. In the hepatobiliary phase, there is some nodular patchy enhancement in this patient. So again, it's more favoring the sclerosing hemangioma because there is no restricted diffusion and there is delayed sort of enhancement is slightly delayed compared to the classical hemangioma. But in the clinical practice, the decision making, it becomes difficult to call sclerosing hemangioma. It's usually a hindsight diagnosis in my clinical practice. So we suggested biopsy. No biopsy was performed in this patient, but this remained stable over 9 years when I was following this patient, almost same as appearance. So we concluded that this is probably a case of sclerosing hemangioma. Definitely cholangiocarcinoma is out of question. And there is no ancillary features here of like capsular retraction or periductal dilatation in this case to suggest as cholangiocarcinoma. So comprehensive evaluation is important in such case. Okay, this is an interesting case recently encountered, but we have few more cases like that. A 51-year-old man with sigmoid mucinous malignancy operated a couple of years back. So this patient had undergone a CT scan that showed multiple masses in the liver. We did MR for further evaluation. So on T2 fat sat images, there are at least 2 masses in the liver, one here and one here. They are mildly bright, but not exactly T2 bright. But they have a margin, quite well demarcated. There is restricted diffusion, and if you carefully evaluate the diffusion, it is the target sign. The target sign is present. There is restricted diffusion in the periphery of the mass, and in the central area is more of a T2 shine through. Unenhanced white, hypointense, and look at the venous phases and the 3-minute delayed and hepatobiliary phase. There is progressive enhancement in both the masses. See this here, here, and in the hepatobiliary phase, classical cloud sign. So we knew from the history that patient has some history of mucinous sigmoid mass. So these are probably metastasis, but and the clinician also knew that this is metastasis, but we have to give a differential diagnosis that maybe these are multifocal cholangiocarcinoma, radiological differential diagnosis, but final diagnosis was confirmed as mucinous metastasis. So learning point is that the mucinous metastasis cannot be sometimes differentiated radiological from cholangiocarcinoma. But that usually this is not it's not a question because you always have a history of a mucinous malignancy in breast or colorectal cancer in such patient or with metastasis. Move on to the periductal infiltrative cholangiocarcinoma. They arise between the second order bile duct and the insertion of the cystic duct. They spread along the bile duct. So, but in practice, a combination of periductal infiltrative and mass forming tumor is more common. So they usually, the MR feature is of periductal thickening, which is hypointense on T1. That shows progressive enhancement, typical signature imaging features of cholangiocarcinoma. Hyperintense on T2 weighted images. They are usually associated with ductal dilatation and ductal narrowing. That actually draw your attention towards the mass, the presence of ductal dilatation. And the most important in practice, is the presence of restricted diffusion in the periductal thickening that makes our confidence high to call it a malignant structure. So here is an example of a patient, 52-year-old man, presented with sepsis and abnormal liver function test, and this is how they usually present. So on the CT scan, single phase photovenous phase, there is just focal ductal dilatation, nothing else. Focal ductal dilatation in the left duct. Portal vein is not thrombosed, but it's attenuated, I'll call it. It's compressed. It's narrow in caliber. It's not invaded by the mass. So the MR was done for this patient for further evaluation. On MRI, there is ductal dilatation in the left side, and the ducts are not as bright as they should be. They are very cloudy, bright, but they are bright. See here, very difficult to make out. Most useful. Restricted diffusion, it was present. I'm not showing again the ADC here because of the lack of space on my slide, but there is bright signals here in the diffusion weighted images. On the contrast phases, there is periductal thickening and enhancement. See, along the duct here, along the duct, involving a long segment of the duct. Typical example of periductal infiltrative cholangiocarcinoma, and this is how they usually present: focal dilatation of the duct, either segmental or lobar, some territorial. So the take-home message is, one of the take-home messages is to never ignore focal ductal dilatation. If you see on CT, do work up on this patient. So this patient came back 6 months later. 6 months later, I have put up the initial CT and follow-up CT side by side, and you can realize 6 months later, the mass is now quite obvious. So initially it was a periductal infiltrating mass. Now it has become a combination of periductal infiltrating and mass-forming cholangiocarcinoma. This is usually the stage when we give the confirmed diagnosis of cholangiocarcinoma. That is not good for the patient, because by this time it's inoperable. It's good to diagnose. It's quite beneficial to diagnose the cholangiocarcinoma at this stage, and that is possible confidently only by a combination of MR and ERCP, as I have shown with this example. Okay. So Klatskin tumor, everybody knows about it. This is the classification of Klatskin tumor. Difficult, looks like complicated slide, but the slide is more useful to understand the classification. So in type 1, only the common hepatic duct is involved without involving the confluence. In the type 2, the confluence is also involved. In type 3A, the right duct is involved, sparing the left duct. In the type 3B, the left duct is involved, the right duct is spared. And the type 4 is inoperable. Both the ductal systems are involved along with the hepatic duct. So this classification is useful for prognostication and for guiding the surgery. So 56-year-old man with elevated liver function test and sepsis. There is a mass here in the hilum with ductal dilatation bilaterally, the right duct as well as left duct on T2 haste images. That's showing restricted diffusion. And in the contrast enhancement phases, there is typical signature of cholangiocarcinoma, progressive enhancement. No doubt this is a Klatskin tumor, and the portal vein was patent in this patient. MRCP is quite useful in these patients in classifying into the bismuth categories. So in this patient, the left duct is where involved and the main duct is involved. So this becomes type 3B Klatskin tumor. In this patient, surgery was not performed. Palliative treatment was given, and due to presence of comorbidity. So this is how a Klatskin tumor looks like. Now we move on to a common scenario that we face in our clinical practice: biliary stricture. So especially the extrahepatic bile duct stricture. I see it twice or thrice in a week. Here is an example: classical cases. 58-year-old man with jaundice. MRCP shows abrupt cutoff of the dilated duct. Bilateral ducts are dilated. 3-minute delayed phase shows that there is some cuff of soft tissue enhancing at the level of cutoff. Axial post-contrast delayed images are useful, showing that there is an eccentric soft tissue here, nodule in the region of the stricture, quite well seen here. So in this patient, since there are presence of two evidence to suggesting the presence of malignancy, so you can comfortably call it a cholangiocarcinoma, which is usually confirmed by ERCP. So this was confirmed after we gave the diagnosis of cholangiocarcinoma. Now we move on to the opposite category of the patient, a 60-year-old woman with recurrent biliary colic. So in this patient, on MRCP, you can see that the ducts are dilated, there are bulged duct calculi, then there is a stricture. Post-contrast delayed images shows that there is a gradual tapering, so the gradual narrowing, that is not abrupt cutoff. On axial images, there is no periductal thickening. What you're seeing here is calculus within the CBD. There is no convincing periductal thickening, and there was no restricted diffusion in this area. So there is no evidence for malignancy. So we'll probably benign, but again, radiologists should be careful calling a benign lesion a benign. You never know. Cannot exclude a mucosal cholangiocarcinoma. But you can give whatever you see, you can describe and favor one diagnosis over other, benign versus malignant. So in this case, we call it probably benign, and the patient underwent again. This patient was stable for 4 years. No ERCP was done, and we concluded that there is nothing, no malignancy in this patient. So our problem here. And question our clinician asked whether the bile duct stricture is benign or malignant. So final diagnosis usually is with the ERCP. We can suggest, we can look for the evidence. So the evidence for malignancy are presence of periductal thickening, usually eccentric, abrupt narrowing, presence of restricted diffusion, but the tumor tissue is so small in volume that very difficult to have a restricted diffusion in that area. Benign stricture, again, it takes a lot of experience to call benign stricture, and it's better to leave this in on the clinician. You can just mention in your report whatever evidence you are collecting towards either of the diagnoses. Move on to the third type of cholangiocarcinoma, the intraductal cholangiocarcinoma. So this is usually present like a polyp, has a papillary growth in the lumen of the bile duct, and there is no parenchymal extension. This one has the best prognosis because it does not invade the liver parenchyma. In clinical practice, you encounter them as a focal or diffuse ductal dilatation with or without papillary mass, and sometimes as an intraductal cast-like lesion with a mildly dilated duct. They have the signature of cholangiocarcinoma, or that how it looks like. So a classical example of a ductal type, on T2 haste images, there is a mass here, mildly bright on T2 weighted images, mildly bright on high B value diffusion weighted images. It was dark on ADC, so there is restricted diffusion, and classical signature enhancement of cholangiocarcinoma progressive in the phases. 3-minute delayed phase shows that the mass is growing within the duct, expanding the duct, and there is upstream dilatation of the duct. MRCP, not the MRCP, this is T2, probably haste. The mass is located in the duct. So this is how the intraductal cholangiocarcinoma looks like. ERCP was done in this patient, and cholangiocarcinoma was proven. I couldn't follow up this case because because the case notes were locked. Sometimes they can be seen on CT scan, like in this case, and in this case, there's enhancing mass in the CBD. Until has proven this has to be malignancy, but in this case, it came out as dysplastic villus polyp. So there are a few other pre-malignant lesions described in the literature, very rare to pick up prospectively. It's usually the benignity is the hindsight diagnosis for us radiologists, clinical practice. Everything enhancing in the CBD is cholangiocarcinoma unless proven otherwise. That I follow that rule. Coming to the conclusions, we must be aware of the signature appearance of the cholangiocarcinoma. The awareness about the differential diagnosis is essential, as I mentioned, the mucinous metastasis from colorectal carcinoma. We should always seek help from the clinical and lab data, and the radiologist, this is very important, that should have high index of suspicion for cholangiocarcinoma when you are assessing focal intrahepatic or extrahepatic biliary strictures. Don't leave the patient alone, follow up those cases. If the clinician does ERCP brushing, even if it's benign, I will recommend, if you know the patient, ask him to follow up maybe 6 months, 3 months, and you may save some lives because listening to me.
Thank you, sir, for that excellent talk. So I think the questions will be coming up. So you can answer them on the chat box, sir, but I would request you to please. So Gauri, I think we can start with the quiz.
Okay, Madhusha, let's go ahead. So the quiz will be taken by Dr. Mitusha Verma, and so the 2 quiz winners will be receiving free registration for the International Online Edition MRI teaching course. So Dr. Mitusha really doesn't need an introduction. She's a consultant radiologist in PET-CT, CTMR at Nanavati Max Super Speciality Hospital. Her special interests on body imaging and radiology advances. Mitusha, I think we can go ahead with the quiz.
Yeah, sure. Thank you, Gauri. And as you all know, the quiz is going to be prize winning. So the last 2 questions are the prize winning questions. And those who give the correct answer first in the chat box will win free registration for this upcoming course, which will be a 5-day entire comprehensive program from 28th, 29th October to 3rd, 4th, and 5th of November. So there are 5 questions this time. This is a short quiz we are having. And I'm going to share the first question now on your screen. And you have to just put your answers in the chat box. Yeah. So there are a set of images. And this makes together one syndromic association. So what do you think it is? So even if you want to be partly correct, that is fine. You can just start putting your answers in the chat box. I can see one answer, juvenile nasopharyngeal angiofibroma. So there is something vascular abnormality which is going on. There is something but intracranial also. So what do you think that is? So this is, now let's see what the answer to this question is. So this is CAMS, which is a short form for cerebrofacial AV, so that is arteriovenous metameric syndrome. So there are facious osseous AV malformations, and there is, in this case, enhancing vascular malformation in the left basal ganglia as well. So combination of AV malformations in the brain parenchyma and in the facial soft tissue and osseous structure. So this is CAMS. Now we come to another next quiz question on your screen. So you have to identify the sign, and what exactly this lesion is. So this is an easy one. So I think you can quickly put answer in the chat box. Yeah, so as is correctly mentioned by Dr. Sachin, this is T2 shading sign, and this is endometriotic cyst or endometrioma. So this is the answer was shading sign. Now the next question, you just have to answer which sign does that picture depict. Only the sign. You can put the diagnosis, that's an additional point, but what is this sign? Yes, so this is T2 dark spot signs. So again, it is also seen with endometriotic cysts or endometriomas. So these are the two signs which help us to identify confidently endometriotic cyst when they are present, as they might be sometimes confusing with hemorrhagic cyst because both of them will have T1 bright content, but shading sign and this T2 dark spots sign, if positive, it means that it is a chronic ongoing hemorrhage which is happening, and these are all clotted or chronic blood products which we are seeing as T2 dark spot, and shading is because of the blood products in different stages of degradation. So these two signs are important to identify endometriotic cyst. Now you have to assign ORAT's category to this lesion. This is your case number 4, and as I mentioned, this is prize winning. So please read the question correctly. There are only 5 questions this time. So fourth one is on your screen. Give me the correct answer and you win the prize of free registration. So you have to assign ORAT's category to this lesion. So as we see, the correct answer is definitely dermoid cyst, as Dr. Sachin Pathak has given the correct answer, but we had asked for the ORAT's category. So 2 of you have given correct answers, Dr. M. Chandramouli and Harveen K. And I think yeah, last quiz, Dr. Chandramouli was a winner, Gauri. So we can consider Harveen K this time as winner for this quiz question. So the category which we assign as per ORATs to dermoid cyst is ORATs 2 category. These are benign lesions. Dr. Chandramouli, you have already won the free registration. So you are the winner, but means twice registration to the same course will not make sense. So definitely we have 2 winners, Dr. M. Chandramouli and Dr. Harveen K. Both of you, please share your email IDs and contact details. Now the next question on your screen. The last question, but again, the quiz prize winning question. So quickly put the answer, easy one. So this was an explanation. So ORATs 2 category for dermoid and endometriotic cyst both. See this lesion. What do you think it is? Give your diagnosis on the screen. And one quick hint, give a LIRADS category to this lesion. Like we gave ORATs category, give a LIRADS category to this lesion. Somebody is asking for explanation for the last question. I'll definitely revise that, Dr. Preeti, in a while. I'm just waiting for the winner for this question and we can get into the explanation part. So I think you people are missing on the LIRADS part. You can just refer to Google and the LIRADS table and quickly put the answer in the chat box. That's also is fine. No problem. But just apply all the LIRADS rule and see where this lesion fits into. And the size of the lesion is 14 millimeters. Yes, so I think now you are on dot and after referring to your reference sheet. So this is Dr. Gauri. I think we can give it to Dr. Zubin for LR5. And again, Dr. Chandramouli, you are correct. So winner to this quiz question is Dr. Zubin. Please share your email ID and contact detail in the chat box. So I think we made this clear that the reference table has to be with us every time we are characterizing the liver lesions, because otherwise it becomes difficult. So as you also saw, once the screen was with your question, quickly you had answered HCC. But when I asked LIRADS, there was a lot of confusion going on in the chat box. So just let us revise the LIRADS table. So LIRADS talk about how do we characterize liver lesion in a background of liver cirrhosis. For somebody who is more than 18 years of age, when there is a high risk of having HCC, that is chronic liver parenchymal disease background should be there, and or cirrhosis should be there, or the patient should be HPV or HCV hepatitis proven case. Then we apply this LIRADS. And based on the size of the lesion and whether it is showing arterial phase enhancement or not, we have these categories assigned. So when we see this with our case and the table in handy position, we see that our lesion is definitely arterial phase enhancing. So we go this side of the table. Then it is the size criteria. Size is 14 millimeters, so which makes it coming into this category of LR3, LR4/5 and LR5. Now, how do we decide between these three? So there are major features which we have to look for. Is there an enhancing capsule? Is there a non-peripheral washout? Or third is threshold growth. So threshold growth, we can't comment because we don't have comparison, but definitely the other two, enhancing capsule is there and non-peripheral washout is also there. So if two major criteria are present with a size of between 10 to 19 millimeters, it is assigned as LR5 category. So this is LR5 category, and the lesion which is above 95% of chance of being malignant or HCC in a background of chronic liver disease. So always make sure that you characterize liver lesion using LIRADS whenever your patient is more than 18 years of age and there is a background parenchymal liver disease like cirrhosis. And don't try to kind of memorize the table because you might get confused while putting in the report. It is definitely allowed for you in your practice also. It's not an exam. So you can refer to it from the net and use this table easily and get into a diagnosis. So these are the major features to always remember: non-peripheral arterial phase enhancement, non-peripheral washout, enhancing capsule, threshold growth, and size criteria. Now, as Dr. Preeti wanted a quick explanation to the dermoid question. So this is dermoid for sure, no doubt. T1 hyperintense, heterogeneous, and fat suppressed sequence is showing that the lesion is now hypointense on the fat side sequence. So there was fat within it. So ORADs, if you read and go through, you will find that dermoid cyst and endometriotic cyst. If it is typical dermoid or typical endometriotic cyst, it is a benign finding. The probability of it being malignant is less than 0.5%, and the category ORADs assigned is ORADs 2. So if you see here, so lesion with lipid content and no enhancing soft tissue is a dermoid and assigned as ORADs 2. A lesion with that T2 dark spot sign or shading sign, which is like endometriotic cyst with blood, or fibroma if it is completely T2 dark. These three lesions are ORADs 3 category. Oh, sorry, ORAT's 2 categories. So benign lesions, ORAT 2 categories. So that was the explanation. And Dr. Chandramouli, you will receive your pre-registration link before the conference actually starts. So don't worry. And thank you all for being there on a Sunday morning for the Prelude session and making it a success. And we have total 6 winner out of the 3 Preludes. So congratulations, and please do attend the entire course as per your feasibility of timing and schedule. It is on 5 days, 28th, 29th of October and 3rd, 4th, 5th of November. The recordings also will be made available for next 3 weeks after the course completes, depending on the consent from the respective speakers. Dr. Gauri, I would request if you could share the screens again regarding the conference detail. And with this, we can come to an end of the Prelude. Thank you, everyone. And I've shared the registration link in the chat box. So those of you who want to quickly register, you can directly copy from there and register. Otherwise, just visit the Indian Radiologist webpage and you will get that link.
Thank you, Madhusha, and thank you everyone for joining us today. And congratulations to the winners. We've shared the link for the registration for the conference in the chat box, and it is also available on the Indian Radiologist website. Also, please do send us your paper and poster entries, and do participate in the Case of the Day contest. So hope to see you all on 28th. Thank you, and goodbye. Dr. Amit, I think we can end the session.